When prescribing opioids for acute pain in the United States, providers really have a lot of choices. And we found that the most common ones that are prescribed are hydrocodone and oxycodone. Hydrocodone is around 50% of the prescriptions to patients who are opioid naive, and oxycodone is around 25%. They're both very similar medications. They both work in the same way. They're both Schedule II narcotics from the DEA, and we think that the risk profile is very similar. So we don't really know if there's one that's more advantageous than the other. And that's really what we wanted to look at the study. We wanted to determine if there's increased risks from both going on to use opioids chronically or to having an overdose, whether you get one or the other medication as a first prescription. In the study, we found that our two main outcomes, either chronic use or opioid overdose, actually varied between the two medications. We found that hydrocodone was slightly more associated with having chronic use, and oxycodone was significantly more associated with having the overdose variable. The two medications are pretty interesting the way that they're formulated. If you look at hydrocodone, for acute pain, for short-acting hydrocodone, it's almost always prescribed in combination with acetaminophen. But for oxycodone, it can either be prescribed separately or in combination with acetaminophen or sometimes with other medications. As a prescriber, we really have a choice about which ones we want to prescribe, especially with oxycodone. I know some colleagues that like to prescribe the two together because they're getting the multimodal medication. They're getting a non-opioid and an opioid together in one pill. It's easier for people to take it, as an example. And some people think that the risk of going on to have overdoses and hurting yourself from overdose is actually less if you have acetaminophen there, because people know that having that in there can actually hurt your liver if you take too much of it. On the other hand, there's the theory that you should separate them out. And this is actually what I do in my practice, which is that if I see a patient that has acute pain, I want them to maximize the non-opioid first, whether it be acetaminophen or ibuprofen. And if I do think that their pain does warrant an opioid, then I want them to take the smallest amount possible on top of the non-opioids and kind of separate them out. But again, before the study, we really didn't know if one formulation was more advantageous than the others for these outcomes. The results were pretty interesting with the combination analysis. When we looked at the outcomes from overdose, it was higher with oxycodone and acetaminophen compared to hydrocodone and acetaminophen, but it was actually much higher with just oxycodone by itself. The adjusted hazard ratio was over 2 times that of hydrocodone with acetaminophen. So it actually does show that having the acetaminophen in there is protective against that outcome, at least of opioid overdose. We did find some interesting trends regarding the characteristics of the patients themselves with regards to age and other demographics, as well as insurance status. We did find that as age progressed, the risk of chronic use also increased. So the younger patients, the lowest age bucket was 18 to 24, had the lowest risk of going on to chronic use, and the highest was patients that were age 75 and greater. We didn't really find a difference between sex and female versus male, but we did find that Black patients were slightly more likely than white patients to go on to develop chronic use. And particularly for insurance, we found that if you have, compared to commercial insurance, either Medicaid or particularly if you're dually enrolled with Medicare and Medicaid, your risk of having chronic use were markedly increased. For the opioid overdose variable, it was actually interesting to see the differences there too. Here, as I mentioned before, oxycodone does have a much greater risk of having overdose. For both formulations, it was 1.65 compared to hydrocodone. And here we found that the age groups actually did make a difference. Here, the youngest age groups, the ones that have a less likely chance of going on to chronic use, actually had the highest risk of having overdose, that 18 to 24-year age group. Women were much less likely than men to have overdose, which we thought was interesting. And then we also saw the same patterns that we saw with chronic use with insurance. In this case, if you have Medicaid compared to commercial insurance, the adjusted hazard ratio was 5 times higher, it's 5.4. And for the dually enrolled, it was even higher than that, it was 7. So for the results of the study, again, the hydrocodone risk with oxycodone for chronic use is pretty similar. So I don't think that there's actually very much of a clinically significant difference for those two medications. But the difference we did see was really for that overdose outcome from hydrocodone versus oxycodone. It's important to put it into perspective. So with the findings, it was 2.4 out of every 1,000 patients who got hydrocodone went on to have an overdose. It was 3.8 of every 1,000 patients that went on to have an overdose with oxycodone. And so in the scheme of things, it's not that many. We're talking, again, 2 individuals versus 3 individuals, but with many prescriptions, that does add up. So I think that not only is it the choice of medication, but it's also about sharing the risk with patients, because hydrocodone is also not risk-free, even though it was found to be safer, relatively safer in our study. So prescribers really need to counsel patients that these are risky medications. They should be taken only when the non-opioid is not working. They should dispose of them as soon as they don't need them any longer, and just caution people about the dangers of these medicines.